I see some familiar faces, which is always comfortable when I need to give a talk. So I'm going to talk about assessing the usefulness of diagnostic and screening tests and predictive models. Statistical analyses, I guess I don't need to tell you, is a huge part of biomedical and informatics research. And it's a huge topic in this area. And very often, these statistical approaches focus on decision-making under uncertainty. In fact, a review of the publications in the Journal of the American Informatics Association found that 62% of the articles that they published in a 7-year period focused on the topics that I'm going to talk about today. So since I only have 45 minutes, I'm going to give you an overview of 4 of the common statistical approaches to assessing how well clinical tests and predictive models discriminate between those with some target condition or a level of risk and those without those in a population. So you're going to see that these measures of test or model performance are not necessarily fixed indicators of quality or fixed indicators of performance. Some of them are sensitive to characteristics of the test or characteristics of the population in question. Others are sensitive to the prevalence of the condition in the population in which accuracy is evaluated. So there's lots of decisions to be made in the areas of uncertainty in decision making, and those focus again on evaluation approaches. So it's really important then to understand what these measures of utility are, how to interpret them, and under what conditions they are most appropriate to be used. Okay. My notes. All right, so we're going to start by looking at all of the possible test or model outcomes relative to actual disease or risk status. So compared to the truth or compared to some gold standard, there are 4 possible interpretations of a test result or a model prediction, right? We have true positives. Those were the cases where the patient really has a disease or they're at risk for some clinical event. And the test result or the model prediction are positive. And then we have true negatives. This is where the patient doesn't have the disease or is not at risk for some event, and the test result or the model prediction is negative. And ideally, we would like every clinical test and every predictive model to classify people as either one or the other of these cases. That's the perfect world, but this very often doesn't happen. We have these areas of uncertainty. We have false positives where the patient doesn't have the disease, is not at risk, but the test or the model prediction is positive, and we have false negative where the patient has a disease or is at risk, and the test or the model says otherwise. So the big question is, how do we estimate the extent of this uncertainty which exists in just about every test or model? Okay. So because we classify or identify people as having a disease or having a risk, or not having that disease or risk, we consider 2 classification indices of test or model performance to estimate how well classification occurs. So the first measure of these is sensitivity. The sensitivity of a test or a model is its ability to correctly identify patients with a disease or patients actually at risk for some event. It's the proportion of individuals with the disease or at risk that have a positive test result. It's the probability of a positive test result when the disease is present or the individual at risk. It's also described as the true positive rate. So a test or a risk model with 100% sensitivity correctly identifies all affected people all of the time. A test or a risk model with 60% sensitivity correctly identifies 60% of the affected patients, the true positives, but 40% of those affected will not be correctly identified. Those are the false negatives. False negatives are the complement of sensitivity. So again, sensitivity, the fraction of the diseased or the at risk who test positive, plus the false negative rate, the fraction of disease or at risk who tests negative, always add up to 1. So how do we go about estimating sensitivity? First, you identify those who are diseased or at risk using some gold standard, some standard that is known to identify these people with a high degree of accuracy. You use broad sampling strategies because you want to obtain a sample that is largely representative of the population of the disease or the risk cases. You test them with a new test or a new model of interest, and then you determine the proportion that are diseased or at risk that are identified as positive with this new model. Okay, and then you have this information and you plug it into the 2x2 table. I'm sure lots and lots of you have seen these 2x2 tables. Sensitivity is calculated as the true positives divided by the true positive plus the false negatives. So the calculation for sensitivity is based on the diseased individuals. Okay, so this is just a little example. There's a new test that's developed to rapidly test for strep. 300 patients in the study group are found to actually have strep. This is verified by the gold standard test. And 180 of these patients return positive results with the new test. You plug it into the 2x2 table, and you find that for this particular situation, it has a sensitivity of 60%, meaning that 40% of the diseased or the at risk will have a negative result or be incorrectly classified. Sensitivity. Okay. The other side is specificity. The specificity of a test is its ability to correctly identify patients without the disease or patients not at risk for some event, right? It's also can be described as the proportion of individuals without disease or not at risk that have a negative test result. It's also described as the probability of being test negative when the disease is absent or the true negative rate. So again, a test or a risk model with 100% specificity correctly identifies all patients not affected. A test or a risk model with 60% specificity correctly identifies 60% of the non-affected patients. These are the true negatives, but 40% of the non-affected will not be correctly identified. These are the false positives. False positives are the complement of specificity. So when you add these two fractions together, they equal 1. Okay. And again, if you want to estimate the specificity rather of a test, you use the same process. Identifying people using the gold standard, using a broad sampling strategy, which is really, really important, testing the non-affected or the non-at-risk with the new test, and determining the proportion that are identified as negative with the new test. You plug it into the 2x2 table, and specificity, the calculation for specificity now is based on the non-diseased individuals, right? So it's the true negatives divided by the true negatives plus the false positives. And applying an example to this, again, if you had a new test developed to rapidly test for strep, and in a sample of 900 patients who do not have strep as verified by a gold standard, 50 patients return positive results with the new test. Plug it in, calculate based on the diseased or the at-risk individuals, and you get a specificity of 94.4% in this particular example, where 5.6% of the disease-free will be incorrectly classified as having a positive result. Right? Not too complicated. So specificity and sensitivity are intrinsic characteristics of a specific test. Sensitivity can be influenced by characteristics of the affected individuals. So you want a test that can identify or detect to some extent the disease or the risk state in this group. So if you're testing for a particular strain of strep, You want that test to be able to identify that particular strain of strep and not something else. Specificity can be influenced by characteristics of non-affective individuals who might have other conditions that also may affect the test or the model. So you need to think about that. Specificity and sensitivity are not influenced by the prevalence of the disease or risk in the population because their denominators are both disease risk states, right? So sensitivity is determined by those with the disease or risk, and specificity is determined by those without the disease risk. So these are intrinsic characteristics of the test. How do people make decisions? So the big question is, or at least this is what I think about, but I've heard other people ask this question, do we always want a highly sensitive test? Is there some advantage to always having the most sensitive test? There's a decision about sensitivity or specificity. Which characteristic is most favorable in a particular test? And the choice of test characteristics is based on a function of need, and it's based on the cost of miscategorizing people, right? So if we're talking about a disease that's not life-threatening, but where the cost of treatment is very high, it's very invasive, there's a high risk for some adverse events or adverse situations due to treatment, then really what you want is a test that is very specific. And this is preferred over the sensitive test. You want to really identify those without the disease as accurately as possible. But if you are dealing with a disease that's life-threatening, if untreated, like always life-threatening if not treated, and survival greatly improves with treatment, and that treatment may not be particularly costly, it may not be particularly risky to the patient, then in this situation, a very sensitive test is preferred over a highly specific test. So again, we can think about high sensitivity, low specificity, and these are not good or bad in terms of absolutes, but rather are numbers to be considered when we're talking about test performance. And test performance relates to need. What do I need this test to do? Who do I need it to identify most accurately? Okay. So up to this point, we've been talking about the 2x2 tables, and we've been thinking about disease or risk status as a dichotomy. The thing happens or it doesn't, diseased, yes or no, at risk, yes or no. But in reality, most measures of biological or clinical characteristics, or if you want to think about some risk scoring system, these are based on continuous measures where different individuals have different values, have a range of different values, and the distributions of those values can overlap. So this means that clinicians and researchers make decisions about where to place a cutoff, and that cutoff will determine disease or risk status. And again, it's based on experience, it's based on need, it's based on the cost of misclassification. So moving these cutoffs changes the relative proportions of true positives, true negatives, false positive, false negatives. Increasing the cutoff or moving it to the right would decrease the number of false positives but increase the number of false negatives. Decreasing the cutoff or moving it to the left increases the number of false positives and decreases the number of false negatives. So sensitivity and specificity of a risk assessment or of a test really depend on where this cutoff is selected. And again, the cutoff is critical. The cutoff is related to need. It's another issue related to decision making. So these things kind of have some fluidity to them. Right? So again, test characteristics can be altered by changing the threshold or the cutoff. And there's an inherent trade-off between sensitivity and specificity. So if you increase one, the other decreases. Lowering the threshold improves sensitivity. You're going to have fewer false negatives, but often at the expense of lowered sensitivity. Raising the threshold improves specificity, but often at the expense of lowered sensitivity. So how else can we think about this? So these are receiver operating curves. I'm sure that many of you have seen them. I actually like them very, very much. I think that they're very useful. I kind of think of them as a thing of beauty, and maybe that's more about me than you need to know. They compare sensitivity versus specificity across a range of value. They summarize this trade-off between sensitivity and specificity. So they provide a graphical representation of the full range of all the possible cutoffs that are associated with sensitivity and specificity by plotting the true positive rate, sensitivity, against the false positive rate, which is 1 minus specificity. So by making this possible for you to visualize the full range of values for sensitivity and specificity that a test can take on for all possible cutoffs, this is really the best opportunity for you to characterize a test. And also kind of, to play with these. What would it look like if I moved the cutoff here? What would it look like if I moved the cutoff there? And kind of, make decisions, again, about how useful a test is. So this is just looking at it in a different way, right? So each point on the cutoff is a sensitivity false positive rate pair, right? 9 is better sensitivity, but there are more false positives. If the cutoff is at 5 in this example, there's fewer false positives, but more false negatives, right? ROC curves are really helpful for comparing cutoffs across studies of the same test. So if you want to evaluate the results, moving the cutoff up and down, you can use these for that. This is just a similar example. Okay. Another very useful aspect of receiver operating curves is the area under the curve. So the area under the curve represents the test or the model's overall ability to differentiate individuals who have the outcome from those who don't. So the closer that the ROC curve, I don't know if this works, is to the left-hand corner, the closer the area under the curve is to 1. And this means the higher sensitivity and specificity of a test, which means that it improves discrimination. Although the area under the curve ranges from 1 to 0, with 1 being a perfect test or model, we generally sort of stop at that diagonal line. You don't want the test that meets the diagonal line because it represents an area under the curve of 0.5, where the discriminatory ability of a test is no better than chance, right? So anything close to the 0.5 is pretty much a useless test. A really good use of ROC curves is to compare different tests or different risk models for the same condition or the same event, since you can plot multiple lines on the same axes. So a test or a model has better discriminatory power than its comparison test if the ROC curve lies above that or the other. Right? And this means that its area under the curve is greater. So in this example, right, the excellent test lies above or has greater area under the curve than the good test, making it a better test. You can calculate area under the curve for these multiple ROC lines. Some statistical programs would do it. There are a lot of online generators that do a really good job of calculating an area under the curve. And you can compare this statistically, and you can do this for both paired and independent study designs. So this reminds me of a project that one of our preventive medicine residents did a few years ago, where she was looking at a risk score to identify children with sickle cell anemia who were sick without having to resort to an invasive test. Basically, the way that they were doing it at this particular hospital that she was rotating on was they would do a blood test and they would do a titer and they would determine if the kid was sick or the kid wasn't sick. And the children and the parents were disturbed by the blood test. So what they did was they developed a checklist, kind of a risk score, that had 10 items. And they looked at the ROC curve for the 10 items and compared it to the blood draw and came to some conclusion about how well it performed. But then the question was, does a kid really need to check off positive on every one of these 10 items? What happens if we have a cutoff that's under 10, right? So multiple lines from multiple risks models. And she did a really, really nice project using this to demonstrate that these multiple lines perform differently.
I have a question. So for any diagnostic test, is ROC one of the, like say, for threshold for labeling for that test? Say you have to be ROC or AUC 0.7 to be labeled for this test used for this disease. Is that a criteria to labeling a test for diagnosis?
It's not a criteria for labeling the test for a diagnosis, but it just tells you how well that test performs, you know, in terms of identifying people with the disease versus those without.
So when, like, say, FDA approved this test for this disease, there's no criteria for that, or is AUC one of the?
I don't know what the FDA process is for approving a test. My guess is that these types of approaches are considered kind of like in the overall opinion. You're shaking your head yes, so you're more familiar with that than me?
Well, I'm familiar with the process of making a diagnosis, and the test is one component. So you're kind of asking two questions. One is it a good test, and the other is how do you make the diagnosis? They're not the same thing.
Okay. Okay. So this table just kind of lays out the general relationship between the area under the curve and sort of classifications of accuracy of a test or a risk prediction model. You know, again, and these are just kind of global measures. You know, they don't tell you anything about parameters of the test. They don't tell you anything about sensitivity and specificity. It is conceivable that two tests could have different sensitivity and specificities, but still have the same area under the curve. So again, you have to look at the whole package when you're trying to come to some conclusion about test performance and not really rely on just one of these parameters. As always, you know, while this looks appealing, kind of eyeballing one is above the other and drawing some conclusion, at the end of the day, you need to confirm that conclusion with a statistical test to really be able to confidently conclude that the differences in lines is really statistically significant. Okay. All right. So, as I mentioned before, sensitivity and specificity are properties of the test or predictive model that estimate its ability to correctly identify or discriminate between affected or non-affected individuals. And this is the test or the model perspective, right? And it's useful for clinicians and researchers, and it facilitates decision-making about which test or model to use. But you can consider test or model performance from the patient perspective by considering the predictive value. So predictive value asks the question, given a particular test result, what is the probability that this patient actually has disease or is at risk for a particular event? And given that there may be certain risks or costs of a particular treatment or for assigning an individual to a particular risk category, predictive value is useful. It's useful for patients, it's useful for clinicians, it's useful for researchers for deciding whether to start treatment or to start some type of risk protocol. So again, this is a patient perspective. So we're back to the very useful 2x2 tables, right? So positive predictive value is the probability of having the disease, the risk, when the test is positive. A high positive predictive value means that there are a small number of false positives among those who test positive. So positive predictive value, the calculation is based on a positive test result. Note that the numerators and the denominators for predictive value versus sensitivity and specificity are different. So in predictive values, the denominator is the test result, and the numerator is the disease state. Sensitivity and specificity, the denominator is the disease or the risk state, and the numerator is the test result. So what's the big deal about this? Again, this means that sensitivity and specificity are not influenced by the prevalence of the disease or the risk in the population, but the positive predictive value is highly influenced by the prevalence of the disease or the risk in the population. So this means that even if sensitivity and specificity remain constant, testing two populations with differing prevalence with the same test are going to give you different positive predictive values. So this is an example of just plugging in, again, to the 2x2 table. Here we have a sensitive test with a sensitivity of 96% and a specificity of 80%, and the positive predictive value is 62% at a prevalence of 25%. Okay, in this case, we have a similar situation in terms of sensitivity and specificity, because the sensitivity in this case is 96%, the specificity is 80%, and the prevalence, though, is 2.5%. And at a prevalence of 2.5%, the positive predictive value is only 11%. Because, again, if you've got more sick people in the population, positive predictive value is going to be higher. If you have fewer sick people in the population, it's going to be lower. Okay. Sometimes there is confirmatory testing, right? You have a positive test, and then you retest those positive people one more time. Confirmatory testing will increase the positive predictive value of a test because there's a higher prevalence of disease or at-risk people in the population. Okay. Most commonly, people talk about sensitivity and specificity. But you can also talk about the negative. They talk about sensitivity and the positive predictive value. But it's also of use to consider the negative predictive value. And this is the probability of not having disease when the test is negative. A high negative predictive value means that a small percent of false negatives among those who test negative. And again, calculation is based on a negative test result. And if you plug this in to the 2x2 table in this example, where we have a sensitivity of 96% and a specificity of 80% and a prevalence of 25%, the negative predictive value in this case is 98%. In this example, where the prevalence is only 2.5%, interestingly enough, we have a negative predictive value of 99.9%. So while the change in positive predictive value that's due to prevalence can be dramatic when you go from a situation of high prevalence to a situation of low prevalence, the negative predictive value may actually largely stay the same, or it may increase a little bit with a change in prevalence in the population. So it's not sensitive to that. It's the positive predictive value that is sensitive to prevalence in the population. And the last measure that I'm going to talk about are likelihood ratios. These are just another means of assessing the accuracy of a test or a model. And the likelihood ratio is, it's a likelihood of a given test result in a patient with a specific disorder or a specific risk compared to the likelihood of the same result in someone without that. So just kind of more simply put, if you have a positive test, how many times more likely are you to have the condition or be at risk compared to someone who doesn't have that condition or who is not at risk? So we talk about likelihood for a positive result or likelihood for a negative result. The likelihood for a positive result, again, is how much more likely that a positive result will be obtained for individuals with the condition. It is calculated as sensitivity divided by the false positive rate. It's interpreted, so if there's a likelihood positive of 6, it just means that a patient with a positive test is 6 times more likely to have the disease than a patient with a negative test. The likelihood, positive likelihood ratio is usually greater than 1 because it's more likely that a positive result will be seen in individuals with the condition than without the condition.
And so this is not sensitive to the prevalence of the disease?
No, it's not. It's not because it's calculated using sensitivity and the false positive rate. So the likelihood ratio, again, characteristic of the test, not sensitive to prevalence in the population, lets you compare across populations for that reason. It's difficult to compare across the positive predictive value. It's difficult to compare across populations because of the issue of prevalence. If there's different prevalence in those populations, it's problematic. But you can compare likelihood ratios across populations. So a likelihood ratio of greater than 10 means that the test of the model has a large effect on increasing the probability of a condition present. 5 to 10 means it has a moderate effect. Anything less than 5 means it has a small to not significant effect. Similarly, the likelihood ratio for a negative result means how much less likely a negative test model result will be seen in an individual with a condition than an individual without it. It's calculated as 1 minus the sensitivity or the false negative rate divided by specificity. It's usually less than 1 because it's less likely that a negative result will be seen in those with the condition than those without the condition. Generally, a likelihood ratio, a negative likelihood ratio of less than 1. The test model has a large effect. If it's greater than 0.5, it has a small effect. To interpret it, right, if the likelihood ratio negative is 0.1, it means that a patient with a negative test has a 10-fold increase in the likelihood of having the disease relative to those with a positive test. Again, I just mentioned sensitivity and specificity are used to calculate the likelihood ratio. Therefore, they're not influenced by the prevalence of the condition. Right. So nomograms are actually really useful for understanding the relationship between the pretest probability of a disease, which is the likelihood of having the condition in a population before testing, the likelihood ratio and the post-test probability without actually having to do the math. And again, these can be found online. There are a lot of institutions that have links to these where you just kind of plug in your information and it does the computations for you. I think they are kind of cool.
So the pretest probability would be the prevalence. No.
It's the likelihood of having the condition in a specific population before testing. So how likely before you tested, how likely is this?
How do you know?
Look, yeah.
How would you know? Yeah, I think it is. Okay, and then.
But this is, all right, prevalence.
Yeah, I think it is
Okay.
prevalence, right? It's
Yeah.
how likely you are.
Yes.
Given the population, how likely are
Yep.
you? Then you perform a test.
And you perform the test, and then there's some prevalence, a proportion of the population that has the disease as determined by the test, and the likelihood ratio explains the relationship between those two. So
what are the two red lines? The first one, the patient, there's a pretest probability of 10.
10, yeah.
And then.
And the
post-test.
post-test probability is 60.
And the likelihood ratio for that one
is more than 10.
More than 10.
Right?
And then the other one, there's a prevalence of
40. But actually the test, it's really quite small. And the likelihood ratio is closer to 0. It argues against disease. So having the likelihood ratio go in, can we see this arrow? Going in the first line, going up, argues for disease. The other one going down argues against disease in terms of that test. And if it's equal to 1, there's no diagnostic value. So if you were to look straight across, right, that line at 1,
But the likelihood ratio of 1, if you started at 40, would point you to a higher post-test probability, would it not?
it actually would go down. Right? If you started at 40, because you'd have to slant it up. It might.
Oh, I
But
see.
if you-
The post-test, it's flipped.
Yep.
Yeah,
Goes from
okay,
0.1.
okay, yeah, got it.
Okay. All right. So taken together, again, with the consideration of context, which is very important, need, and the cost of misclassification, these indices of test or model performance are really powerful tools. But my final word on this, because I spend a lot of time talking to people about research, is that ultimately these measures are highly influenced by the quality of the study design and the quality of the data that you collect, right? So if data are collected in not a great way, if there are studies that are conducted with methodological flaws, these flaws can potentially under or overestimate these measures of test and model performance. So this is just one more area of complication to throw into your ability to draw conclusions about test performance. In addition to the issues that I've talked about when evaluating evidence, when evaluating guidelines and things like that, and going back to the original studies that these evaluations were based on, again, to kind of look at the quality of the studies from where these numbers came from. Okay? And that's it. I have some references. Some of these links are live as of yesterday. As of this morning, some of them weren't working, and I don't know why. Any questions?
So would you agree that measuring predictive values as a weight, as a statistic, is not really low? Like, most people don't really...
Yeah, most people don't report it, but for the purpose of completeness, because I thought if I left it out, somebody would raise their hand and say, well, what about negative predictive value?
But as a stat, it's
Yeah, it's not. It's sensitive. Most studies, most people, if you look at the published literature, most people talk about sensitivity and positive predictive value as